Thank you for joining us today. I have Dr. Eric Wallace. He's the Medical Director of UAB eMedicine, and he'll be here to give you some information on telehealth options and where eMedicine options stand.
Yeah, I appreciate everyone inviting me to come talk here. I think that telemedicine got a big push when the Center for the CDC actually said we need to leverage telemedicine as a way to combat COVID-19. At the time when that was mentioned, there was relatively little reimbursement options. But what's happened in our state all at once, really, on Friday, is there's been a massive change in the way that the way that telehealth is actually reimbursed, which is making all of this possible. So really, overnight, there's been a lot of things that have happened to try and transition things to remote care for a lot of reasons, which is, number one, we need to be able to triage COVID patients in their home. We also need to be able to keep patients out of the hospital when they don't need to be. So, for instance, if you have a urinary tract infection but have no COVID symptoms, we need to be able to treat you in your home so you don't come into a waiting room where there are potentially very ill patients. So the way UAB approached this when we actually started planning for a telehealth response to COVID-19 was actually to think about what are the approaches we can use with telehealth. So the very first thing we did was say we need to protect the front line. We have to protect people in our hospital, in our clinics, to try and limit their exposure, because when healthcare providers get exposed, they have to be quarantined. It then reduces the pool of healthcare providers that are there to be able to care for patients. And so what we did first was we stood up telehealth carts in our emergency room, our ICUs, and our floors that were designated for COVID-19 patients. And the way these are currently being used is for any contact with patients that are either persons under investigation or COVID-19 positive. If there is no reason to enter that room, the providers are able to video conference directly into that room, thus ensuring that they have as limited exposure as possible, but also limiting the use of personal protective equipment, as there may be potential shortages in the future. So that was really our first step, was to create video isolation to assist with that. The next thing we needed to do was for employee health, which is find ways to identify patients and help employees that have been potentially exposed, triage them and be able to manage them in their home, as well as be able to manage when they could potentially come back to work. So that was number two, which is, once again, how do we make sure that we have an existing staff that is healthy and able to deal with the onslaught of cases that is likely coming. So after that, we said, how are we going to do this in the patient's home? So currently, UAB eMedicine has a platform called Hypnosis. This has been live for quite some time. So patients can go online. If you just search for, if you go to the UAB1 site, there is a link on that site. If you go to the internet and just search for UAB eMedicine, then you can also get to that site from there. Patients then start a visit based on their symptoms. There's a specific COVID-19 module that actually helps triage. So, for instance, those who are lower risk versus higher risk, and assist with giving those patients information on the best way to actually go about this. If you have a low-risk viral sinusitis, you're not febrile, et cetera, it will actually be able to treat you. This is all manned by providers. So the patient takes their own history, and then there's a provider that actually reviews that data. So we encourage all patients to actually try to use that site, because there will be a lot of patients coming in person, and thus potentially risking exposure to patients who don't have COVID-19. We are in the planning stages and near finished with actually being able to provide video visits for urgent care, being able to be done directly to the patient's home. We will have more on that in the near future, and we'll make sure everybody knows when that is available to be able to be treated on demand by video in the patient's home for urgent care. However, what's coming right now, there's another group of patients that we needed to worry about, which is patients who have follow-up visits, specifically today. So we're in a state of emergency. What do you do if you have a visit that has already been scheduled, but you're over the age of 60, you're immunosuppressed, cancer patients, diabetes, et cetera? So we needed options for those, because also coming to the clinics would not be advisable if you can avoid it. There will be things that have to be done in person because they can't be handled over telehealth, but for those that can be handled over telehealth, we are trying to convert those patients to phone visits. So if you now as a patient should have options, and they may not be today, but some are converting today, tomorrow will be more, et cetera. So if you're thinking about canceling your visit, know that it's going to be incredibly difficult to reschedule everybody who cancels in the next 2 to 3 weeks for a later visit. So try and consider the options of changing your visits to a telephone visit, which will shortly be a video visit for when those capabilities exist, which are hopeful to be end of next week, end of this week, beginning of next week to start video visits. But please consider, if you're in any of those categories, and even if you're not, to convert your visits to telephone visits. So the other things that, and really the last bit of this, which is that there is the potential to have overwhelming numbers of people needing a critical care bed. And so the management of COVID-19 right now is largely supportive, specifically as it relates to ventilation of patients with acute respiratory distress syndrome. There are critical beds out there in Alabama that are not as well utilized and don't have, for instance, pulmonary critical care oversight for these high-risk ventilation supervision. UAB eMedicine already has telecritical care up and running at 4 hospitals, and we are working to expand that to both increase the workforce at these facilities, but also have an option if the potential is that UAB ICU beds become full, we can export and use external beds to actually manage these patients in a very safe way. We are in the planning stages of tele-infectious diseases also to support, which Dr. Marrazzo is going to come on after me. But those are really the approaches that UAB eMedicine has started and are working furiously to ensure that we have options for all of these use cases to protect our patients.
Great. We can open it up to questions. If you're on the call, does anybody have a question they want to start with?
Yeah, Doctor, this is Henry Thornton with Yellowhammer News. So you said that video follow-up visits should be available early next week, and you said specifically that this would help patients over 65. In your best estimate, is there a significant percentage of those patients over 65 who would have trouble interfacing with the technology necessary to set up one of those meetings?
Yeah, that's a great question. So it turns out the answer is that is the potential. Now, as we have had, so there's a couple of ways to deal with that. So when I started telehealth about 5 or 6 years ago, almost all of my patients were over the age of 65. And many of my patients could not do this at home. Now, fast forward 5 years, when there was the ability to do home dialysis patients in their home. And it turns out every one of my patients had a smartphone. And the reason is that now they're not even selling the flip phones anymore. So right now, usually patients will have a smartphone. The technology piece of this is actually very simple. We created it to be as simple as possible. I think there will be issues with some patients not being able to have enough internet connectivity in their home to do these. So I don't think that everyone will be able to have the technology to do video conferencing. I do think it'll probably be about 80%, which is in our experience about what would happen. For those who don't have the technology or are not tech savvy, above that age and who are at the highest risk, there's a couple of options. Number one is many of those patients have family members who could be at the house. So in that case, we actually set up the family member. So these are sons, daughters, et cetera, who are now in the tech age that help their parents with this technology. The other option is that if we are unable to do a video conference, we can flip those patients to a phone visit. It is not, however, the goal that every single visit would actually be able to be handled over video conference. There is definitely going to be sick people out there. There are going to be medical conditions that we cannot handle over video. So I don't want to give the impression that every single patient will be able to do this. We're going to try and minimize the risk as much as possible, but if somebody has to come in, we will have in-person visits, and those options will be available. So this is just to try and limit as much exposure as we possibly can. So we're going to try and get to everybody. Where we find gaps, we will actually learn about those gaps right now so that we can actually propose fixes to those gaps, hopefully when all of this is over in a very short period. But if there are internet connectivity, then we can very easily identify where we have to focus as a state to make sure that we are very, very well prepared for telehealth delivery of healthcare in the future.
Good question. Is there any other questions from the group on the call?
Hi, guys. I'm Landon Wexler with CBS 42 News. I just got a question. So when it comes to deciphering between those who are visiting in person versus those who are going directly to the telehealth, at what point do you draw the line? Do you want people to be calling in versus making the visit in?
Yeah. So this is one we've just put out all our privileging information. And it's something that we teach providers. The decision of what can and cannot be handled over telehealth is a clinical decision at this point. And so what's going to happen over the next week, since everybody is learning and trying to very rapidly shift an entire healthcare system to remote care, or as much of it as possible, many patients will be switched to phone, and then if it's unable to be handled over the phone, the clinician will then make the decision on whether or not to flip that patient to either an in-person visit or a video visit. As we get further out and all the processes are complete and scaled, then what would happen is at the time of scheduling of the visit, the provider would make that decision of who can and cannot be a video visit. The other thing that'll come out of this is protocols. So as providers learn, so I've been doing this for 5 years, so I know very well which diagnoses I can handle over telehealth versus which ones need in person. So I definitely anticipate that each department, because this will not just be internal medicine or nephrology, this is across the board, so each department will create their own protocols on these group of patients are okay for phone, these group are video, and these group are in person, so that we can streamline the process even further. So all of this is in creation. I think at this point, people are working really 24/7 to make sure that this is safe, this minimizes exposure while ensuring as good a health care as can possibly be given, which is really the UAB standard.
Are there any other questions from the folks on the phone? Okay, if there are no further questions for Dr. Wallace right now, we are going to transition and have Dr. Jeanne Marrazzo, who's the director of the Division of Infectious Diseases, come on. We'll put the folks on mute that are on the phone for 1 moment. Great, so we have Dr. Jeanne Marrazzo. She is the director of the Division of Infectious Diseases here at UAB, and she will be able to comment on the status of COVID-19, social distancing, who really needs testing, more on testing, etc.
Yeah, thanks, Savannah, and thanks to everybody for joining us today. So I think that as everyone is aware, we continue to see an explosive increase in the number of cases identified of COVID-19 globally. There are now several countries that have dramatically increased their restrictions on travel, increasing their social distancing measures, and of course in the last couple of days have seen all but one state report identified cases in the United States. And in the states that are reporting, we continue to see exponential increases in the numbers of cases. And in fact, we're anticipating essentially a doubling of cases every 1 to 2 days. Here in Alabama, we identified our first case last Friday. And we are now experiencing or have detected approximately 22 cases involving 8 counties at least. The majority of those detected infections are in Jefferson County, but I would urge people to understand that the distribution of where we are seeing these cases has very much to do with where we are testing. So notice I've been using the term cases detected. That doesn't necessarily equal the number of cases, because we are still severely limited in our ability to rapidly diagnose these infections, largely due to the same troubles that we had last week. The diagnostic tests have not really been made available. The facilities to run these tests in an accurate way are still not adequately resourced, although that's getting better. I do think the testing backlog will get resolved in the next several days, but it is giving us quite a lot of challenge right now. So just globally and nationally, I would say extreme concern about the expansive growth of this epidemic/pandemic now. The other big challenge with that growth has been continued strain on the healthcare system. So in the parts of the country that saw this wave of infections before we did here in Alabama, like Seattle and Boston, a few other places, the California cities, their healthcare systems are under increasing strain to the point where even well-resourced systems like Seattle-King County are really starting to experience a lot of stress. And that means that people are really running out of intensive care unit beds for these people. There are discussions of whether we're going to have enough ventilators for people who need respiratory support. And I say that not to be alarmist, but also because if you look at what's happening in Italy, they are in a really serious situation, much, much worse than any place here. If you track the likelihood of our getting to the point where some cities in Italy are, we are about 2 weeks behind Italy. So if we do not take this seriously and really pay attention to the social distancing measures that are under discussion, and you're probably going to hear more about tonight from Jefferson County, I'll come back to that, we really will not have the chance to change the trajectory that Italy is experiencing. And that's, I think, a huge shift in tone in the last 4 days that escalated over the weekend, both from our federal government as well as our regional public health leaders. So major increase in cases, lots more emphasis on social distancing. I think you know that several cities have now enacted a ban on restaurant, bar service, a number of measures, also strict limits on gathering size. And as I mentioned, you will be hearing more from Jefferson County Health Department this evening. There's a press conference at 5 o'clock where further measures to protect the health of our communities will be discussed. I'll stop there unless, Savannah, you'd like me to touch on something else.
Do you mind talking just about testing and who needs testing?
Sure. Thank you for reminding me that. So I think you're aware that last week a couple of sites opened up for testing that people could refer themselves to in the community. That resulted in very long lines, lots of waits, and some of the people who were waiting in those lines were actually really ill people, which is not exactly what we want to see. I really want to emphasize that, as our National Institutes of Health Director Dr. Fauci said on Meet the Press yesterday morning, he has not taken a test because he does not have symptoms. People were asking him why didn't he get a test when he handled the same microphone that Donald Trump handled the previous day, and we know that President Trump has been around several people who were infected and had taken the test. Dr. Fauci emphasized that because he did not have symptoms, he did not need the test. And I really want to emphasize that if you do not have symptoms and you feel well, the best thing you can do is to stay well and keep yourself as far away from anybody as you can, as we've discussed, about 6 feet for social distancing, but certainly away from people who are sick. And the flip side of that is, if you're sick, please stay home, do not go out. If you need medical care, as Dr. Wallace just mentioned, that's a very different story, and you need to get yourself taken care of. And you may need a diagnostic test. We have prioritized testing for 4 general groups, and the bottom group is asymptomatic people. So we really do not want to use these scarce tests on people who don't have symptoms. The most important people that we need to test are our critically ill patients who are in the hospital, and that's for a couple of reasons. One is we need to protect our healthcare workers. I think you've been hearing that the number of healthcare workers who are infected has started to increase. We now have healthcare workers who are infected not only in Italy, which has a staggering number, but also in New York City, in Boston, in Seattle. So this is basically an occupational hazard for people who take care of critically ill patients. So we really need to know who those patients are. We're not going to treat them any differently. We're going to do as much as we would for any other patient, but we do owe our healthcare workers, I think, the knowledge about what patient status is. The other really critical thing I want to emphasize is that if we know someone does not have COVID-19 and they are in an intensive care room, or they are in the hospital, or they're on a ventilator, then we don't have to use the intense personal protective equipment, the shield, the mask, etc., that we are currently using for COVID-19. We are running out of those supplies like every other hospital in the world at this point. So we really, really need to know what the status is, and we really need to prioritize the tests for people who need them so that we can take the best care of them that we can.
Great. We'll open it up. For those that are on this call, does anyone have a question for Dr. Marrazzo?
Hi, Doctor. Landon Wexler with CBS 42. State Health Officer Scott Harris went on today, addressed the state, saying that there really isn't too much of a shortage of tests right now. Have you noticed that? Do you think specifically that we need to be limiting testing right now?
I do. And it's a matter. It's a technicality a little bit, because there can be tests available, but to have laboratory capacity and personnel to run them, people to provide the results, that's a whole other level of operationalization that we are still working on. So right now, we're still operating in a situation where it's taking us 48 to 72 hours to get test results back. That's not okay. We need same-day testing. We need test results really quickly. Even cities and laboratories that are well-resourced right now are calling for person power to help them conduct tests when they have the kits available and the reagents or the chemicals available. So I think in a perfect world, anybody who wanted could get a test, that would be fine. But right now, we are really not there yet. And I want to very much support Dr. Harris. He's doing an incredible job. His staff are doing an incredible job, trying their best. But the demand is really outstripping the resources that we have everywhere in the country and probably everywhere in the world.
Is there another question from the folks on the phone?
Hey, this is Chip Brownlee with the Alabama Political Reporter. Dr. Marrazzo, I was wondering if you were, how you feel about the way that the state has handled this so far, and also what's your read on the preparedness level in terms of ventilators? I know you just talked about that, but do you have any concerns for Alabama in particular that we'll have enough ICU beds and ventilators to handle this if the cases keep growing exponentially?
Sure, great questions. I think that the governor has taken it very seriously. She's convened a task force of which I'm a member, and Dr. Harris is the leader. We've met several times in the last several days, and I have a call actually at 1 o'clock today. The leadership has been incredibly receptive to our suggestions and our feedback. So I think based on the state of emergency that was declared last Friday, the administration has been very responsive. I do think that as you'll hear more emphasis, particularly from local health departments like Jefferson County, on some of the more aggressive social distancing measures, that the state government is going to need to amplify those messages. So I think we're going to, you saw all the pictures of people partying this weekend for St. Patrick's Day, all the invulnerable people out there at the bars. I'm happy for them, but I'm very worried for us. I really don't think people should be out doing that right now, and we all have to give a little bit to protect our communities. So that's a really important message, and I think the governor will be very on board with that, given the data. Your second question about ventilators is a great one. We have, for example, at UAB hospital, I think it's about 300 ventilators, so we have a lot. Is that going to be enough? In Italy, they don't have enough. They are actually having to make decisions about taking people they believe are not going to survive off ventilators to reassign them to people. We do not want to be placed in that excruciating situation. It's about the worst possible thing I can imagine as a physician, talking to a family about that or dealing with that. I don't believe there's any indication we're going to get there, but again, my assurance is all based on my belief that we can deflect this curve and not be where Italy is right now. I like your question about the rest of the state, though, because we well know that many rural hospitals have been closing, right? We've been losing a lot of our smaller hospitals. Even those that have remained open may not have a deep staff to take care of critically ill patients. That's when things do get frightening, and you do need to think about expanding your capacity at a place like UAB or a central place. We have contingency plans that we have been discussing, so this is basic disaster preparedness that people are actively pursuing. But I want to reassure people we're definitely not there, and we will be keeping very close track of this and updating you all as it comes on.
Any further questions from the call?
Yeah, Doctor, this is Henry Thornton with Yellowhammer News. Are there any healthcare workers you're aware of at the UAB hospital who are struggling to get to work, struggling to fill their hours in the wake of many school systems closing and children being at home?
Yeah, that's a very good question. It's something we're very sensitive to. I don't have personal knowledge other than to say that I've talked with some people who are single parents in particular, who are looking at making arrangements for childcare that are going to incur additional costs that they would not have planned otherwise. What we and other groups are trying to do is to accommodate people in those situations, and basically the telemedicine option is a fantastic option for them, which is why we're so grateful that Dr. Wallace and his group have been working pretty relentlessly the last couple of weeks. So we're trying to triage people based on what they can do and what will support their home environment and situations to the best that we can. But I have no doubt that taking care of your families at this point, when we're asking you to also help us take care of patients and communities, is an incredibly big stressor on top of everything else that people are credibly worrying about.
Any other questions from the call? If no more questions.
Dr. Marrazzo, this is Chip. This is Chip again. I'm wondering what you think about, some people have suggested that some of the hospitals across the state that have closed might need to be reopened. I'm wondering if you, given your experience, how likely you think that would be to happen. Like, what would those places have to do to reopen to deal with this if we can't bump the curve?
Yeah, I mean, it's a great question, and I think anything's on the table right now. It's if we come to that point, and again, we should have much more data in hand over the next week, I would say. If we come to that point, what that means is we're looking at capacity beyond our immediate medical systems. That means either repurposing existing facilities or creating temporary new facilities, which is also a pretty heavy lift. What would have to happen is you'd have to obviously make sure the infrastructures were capable, and you'd have to, more importantly almost, staff them up with people who are capable and willing to do that. So that's a pretty big step. People are, I know, in active discussions about that contingency planning as part of the disaster preparedness response. It's really no different than thinking about a mass casualty like you might have with a hurricane or an earthquake or something like that. Unfortunately, you have an infectious disease, so it's a little bit more dynamic and ongoing than either of those things. But I do know that people are talking about it, and we will be updating you all as those discussions proceed, and if they do proceed to anything more concrete.
Further questions from the call? If not,
I have one more. Sorry.
Sure.
There are a lot of things going around on Facebook right now, like memes that say if you gargle salt water that you'll prevent infection of COVID-19. Can you talk a bit about some of the disinformation that's going around and where people should go if they for medical advice?
Yeah, that's a great question. Desperate times, desperate measures, right? I've seen everything from that Listerine sort of approach to a lot of natural products, including plant-based products, which several people have asked me about. For credible medical advice, there are several sources. The CDC website is really excellent, and it's cdc.gov. It has a consumer facing page as well as a health provider facing page. Very good at thoroughly trying to take on some of these myths. UAB has a very nice coronavirus page that also has good information for consumers. That's uab.edu/news, I think, /coronavirus. So do check that out. I would say that if you haven't heard about it from these kinds of events, then it's probably not credible. So gargling, I don't think is going to be helpful. Remember, this is a virus that likes your nasal pathway, right? It's like your nasal mucosa. You're breathing in this virus, and the first place it likes to establish infection is in your nose, and the tissues deep in your nose. And I don't think a neti pot is going to do it either, since I'm going down the nasal pathway. So I really think just being very clear, the thing we know works is hand hygiene and social distancing. Stay away from people who are sick in any way, even if they just think they have the sniffles. I would try to stay away from them and use all the good hand hygiene measures that we have discussed previously.
And we're going to take two questions from Facebook. So the first is, does the pneumonia vaccine help prevent patients with COVID-19 to then develop pneumonia?
That's a great question. So we do know that for older folks, we recommend a couple of vaccines to prevent something called pneumococcal pneumonia. That's a bacterial pneumonia caused by a bacteria called Streptococcus pneumoniae. Very, very helpful in older adults. There's a similar vaccine for kids that helps them not to get otitis media or ear infection. So it's a great vaccine. It will not protect against viral infection. So it's not a viral pneumonia protector like influenza vaccine, which is a viral pneumonia protector. That said, so it won't protect you from COVID, but it might protect you and could protect you, in fact, probably will protect you from getting a bacterial pneumonia like pneumococcal pneumonia, which, should you get it, will really debilitate you and put you further at risk if you do get COVID for having some of the really bad outcomes. So I would say vaccination with streptococcal pneumonia vaccine is a great thing to do if you're an older person, just again to tee yourself up to be as healthy as possible as you can should you come across COVID-19.
And one further question is just, there are a couple of people who are asking that if you are insured and have symptoms but can't potentially afford that $150 to go to a drive-through lab, what are your recommendations for those folks who may be in a vulnerable spot?
So the folks who aren't insured, is that what you said?
Yes.
Yeah. So if you are not insured and you feel you need to be tested, you can get tested. Again, the caveats are the delays in testing and whether you really need it. So if you are sick and you feel like you have the flu and you don't have insurance, don't let that deter you, because there are assurances now, and I apologize, I don't know the details, but there are assurances that people will not be penalized in that situation. So everybody should have access to the test if they need it. That said, if you feel well enough to go to the ambulatory setting there and get in line and get your test, please, I beg you not to clog up the emergency rooms to get the test, because we need to keep the emergency rooms for people who really need emergent care. So it's a little bit, I don't mean to have a mixed message. I want you to be able to get the test if you're sick, but think carefully about whether you need to go to the ER before you go. If you have a healthcare provider, you can always call them and they can direct you to some other places. I will add on to that, and I may have mentioned this before, but the health department is working closely with us here in Birmingham to open up another testing site, probably on the premises here of the healthcare campus. So you will hear more about that tonight, likely from Dr. Harris and the Jefferson County Health Department. So we're working on reducing those barriers, but we are also dealing with some challenges too.
Thank you.
Thank you all.
We will let you know if we are going to be continuing doing some news briefings. We plan to do these regularly, and you can, like Dr. Marrazzo said, visit uab.edu/coronavirus for up-to-date information and statements.